Welcome to the first session of the special ACE monthly series, Delivering Cancer Care in the COVID Era. This session will cover practical approaches. I'm Jen Wood, Meetings and Administrative Manager for ACE, and I have a few housekeeping items before we begin. The ACE membership year ends on June 30th, and we're pleased to share with you that we will be rolling out a new and improved membership renewal platform. ACE members should be on the lookout for an email with additional information regarding the launch of the new membership site in early June. This webinar is being recorded and will be posted to the members-only section of the ACE website. Everyone in attendance is on mute, but we will be pausing throughout the webinar for questions. So if you think of anything during the presentation, please submit your questions through the question box in the GoToWebinar toolbar. It gives me great pleasure to introduce today's webinar moderator, Nancy Bookbinder. Nancy's 35 years of experience working with the oncology community includes consulting and collaborating with hospitals, health systems, physician practices, government programs, foundations, and national oncology associations. In 1990, she founded Oncology Resource Consultants and was the firm's president for 29 years. This past year, Nancy was a principal with ECG Management Consultants and a co-leader of the firm's oncology consulting practice. Early in her career, Nancy served as executive director in both an academic and a community cancer center. She's a board member of the Association of Cancer Executives and serves on the Henrietta Lacks Advisory Board. Nancy is the first recipient of the Association of Cancer Executives Marcia Fountain Award for Excellence in Cancer Administration. We hope you enjoyed today's webinar. Please take it away, Nancy.
Thank you, Jen, and thank you everyone for joining us on this webinar, which is the first in a series of webinars brought to you by the Association of Cancer Executives for our members. Key goals for the webinar today are to both share experiences and learnings from our panelists, and also we want to hear from the webinar participants. Your questions, responses, tips, and lessons learned can be forwarded during the webinar using the chat function. Each panelist will include a few minutes at the end of their respective presentation for questions and comments submitted by the participants on the webinar related to that panelist's topics. I will forward those questions to each speaker. The last few minutes of the webinar will be dedicated to hearing from participants on the webinar about your areas of interest for future COVID webinars so that the series can be crafted to address the membership's interests. It is my privilege to introduce our distinguished panelists. They will cover an array of topics related to COVID-19, ranging from science, clinical care, and operational challenges, and changes addressed at their respective institutions by their care teams. Melissa Childress is the president-elect of the ACE Board of Directors. She is the Vice President of Cancer Services at the Winship Cancer Institute of Emory University in Atlanta, Georgia. Her role and responsibility is helping to drive coordinated cancer services along with hospital and clinical leadership across multiple hospitals within Emory Healthcare, with the goal of having a Winship clinical care model that is consistent and seamless, as well as patient and family focused and research driven for all types of cancers across all locations. Prior to her work at Winship, Melissa was Associate Director for Business Development at Ohio State's Comprehensive Cancer Center and the James Cancer Hospital. During the webinar, Melissa will share Winship at Emory University's approach to COVID-19. Another panelist, Joel Helmke, is the Senior Vice President of Clinical Operations for the City of Hope in Duarte, California, a suburb of Los Angeles. He brings over 20 years experience in NCI-designated academic cancer centers. Joel's extensive experience includes hospital operations, clinical program development, ambulatory care delivery, and research administration. Joel will be speaking just today about the City of Hope COVID-19 experience, best practices, and key learnings. And now for the introduction of our first speaker, Dr. Vijay Trisal, who is Chief Medical Officer of City of Hope. As a surgical oncologist, Dr. Trisal focuses on individualized patient care in the context of the patient, their interest and expectations, and their family. He's a member of the NCCN committee formulating treatment guidelines for melanoma. Dr. Trisal studies novel genes that may help in early detection and treatment of melanoma, and the use of isolated limb infusion delivering high-dose chemotherapy to treat locally recurrent disease. Today, Dr. Trisal will provide us with a scientific and clinical overview of COVID-19, as well as testing, treatment, and physical prevention. Thank you for being with us, Dr. Trisal.
Thank you. Good morning, all. Thank you, Nancy. Thank you, Jen, for inviting me to this. Does everybody hear an echo? There might be some people who may need to go on mute. So my job today is to introduce you to somebody, some things that you may not want introduction to you to have, and that introduction is to the COVID-19, the novel coronavirus that we all are facing right now. Next slide. So here is a micrograph of the virus itself. So the area that you see here, the round magenta objects that are interspersed with those finger-like projections. So that finger-like projection is on a cell, and on the cell are these rounded objects which are the coronaviruses. And as you may have heard, the title comes from this resemblance to the sun, to the corona, with these small spikes at the end. So imagine you have like a tennis ball with small claws on top. Those are the coronas on top, and those are the antigens that would connect with these finger-like projections, which are the receptors on the cell, and that's how that virus would get access to the cell. And I realize this virus is an RNA virus. Normally, as human beings, we have DNA in our body, we have RNA also, but the DNA is the driver of the cell. In this RNA cell, they don't have the ability to multiply by themselves, so they cannot divide like a bacterial cell. So what they do is through these receptors, they enter into the cell, and then they take the machinery of the cell, which is the DNA, and they incorporate and use those tools to multiply. So here is one virus with an envelope. They don't have a nucleus like most cells do. They incorporate into the DNA of the cell, they use the machinery, they multiply, and in that process, they end up destroying the cell and creating the damage that they create at different levels. Next slide. So we know hundreds of coronaviruses. There are hundreds of coronaviruses that are in this world. Majority of them are in the animal kingdom. And as you know, that this COVID-19, which is the novel coronavirus that got incorporated into the human, came through a process that went from bats and probably from pangolins, transformed, and was able to infect humans. But even without this one, there were 4 other coronaviruses that already were causing disease in humans. Now realize that disease was a very insignificant or a low acuity disease, like a bad cold. We know that there are these rhinoviruses, and influenza is another virus, but this mild infection that these coronaviruses caused, you have on top these 4 coronaviruses, and they would cause this mild disease. We'd just say, we got a bad cold, I have sniffles, would go home, and next day would be fine because it was not as invasive as the 3 coronaviruses that are at the bottom. And these 3 coronaviruses, one of which caused a significant outbreak in 2002, another one caused a significant outbreak around 2008 and 2012, which was the MERS coronavirus and the SARS coronaviruses. You see the envelope in all 3 of them has this radiating lines that makes it look like a corona, like the sun. And the MERS was the one that was called the Middle Eastern Respiratory Syndrome and started from camels, while as the SARS which was the systemic adult respiratory syndrome, and that was a beta coronavirus causing significant acute respiratory syndrome. But the novel coronavirus that we're dealing with now is being much more rampant and has had pandemic impact. And as you know, that millions of people have been infected by that, and hundreds of thousands have died across the globe. And United States has unfortunately been hit pretty hard, especially in the New York, New Jersey area. And we'll go deeper into why that has happened with this virus and hasn't happened as rampantly with the MERS or the SARS or even viruses like Ebola viruses. Next slide. So here is the concept I want us to understand, is the concept of what's called R0, R0, which means that if there's one person who is infected by COVID-19, how many potential possibilities of infection, how many people would that person infect? And if it infected X number of people, how many of people have the risk of dying? So on your X-axis is this case fatality rate. That means how deadly is the virus. And on your Y-axis is the contagion rate, or the R0 rate, or the R0 rate. If you went to the right extreme, you see measles there. Now, measles is a very, very infectious disease. That means one person that is infected with measles can infect up to 15 people. And this is if we are not using all these limiting interventions, like we're not doing social distancing. Measles can be very rampant. We had this outbreak of measles here in Disneyland a few years back, and it was so rampant that even subclinical disease could be spread, especially in people who are not immunized. Now, on your X-axis, you'll see this case fatality rate. That is the bird flu, Ebola, MERS, which have a very high case fatality rate. That means there's a 10 to 15% risk of dying if you got Ebola. And in the middle, you see the new coronavirus, and the estimated range, which as we get more data is decreasing. It is estimated that the R0, that means the chances of infecting other people, is somewhere around the 2 to 3 times. And as we increase the use of masks, as we increase the use of hand washing, as we increase the use of social distancing, or what I would call physical distancing, I don't want to be socially distant from people. There are other ways to keep socially connected, but physical distancing, as we put those interventions in place, I know that we can decrease the R0 to closer to 2 and closer to 1. And only when we use that R0 closer to 1 will we have better control of the expansion of the disease. Now, the other thing I want to point in this slide is the case fatality rate. That means how many cases do we know of that eventually died? And that is also a changing number based on how many people are you testing. Because if you're testing 100 people and 50 of them are asymptomatic, as an example, then you know that out of those 100, if one person died, the case fatality rate would be 1%. But if you're only testing symptomatic people, if you're testing those 50 people that are symptomatic and the same one person dies, then the case fatality rate would be twice that, it would be 2%. So case fatality rate is dependent on how many people you test. In countries where testing is not as ubiquitous, the case fatality rate is much higher because the denominator is smaller. And this concept of contagiousness and case fatality rate is a very important concept, because the deadlier the disease, as you see in smallpox or Ebola, the less contagious it is, because most of those people who get that disease are symptomatic. And then when they are symptomatic, we isolate them, and we know that they die from the disease, so there is not this subclinical or asymptomatic spread. While as in diseases like coronavirus, it has this right blend of being infectious, being contagious, and being subclinical and being asymptomatic, and having a moderate case fatality rate. I would say that the case fatality rate is somewhere in the 1 to 3%. Next slide, please. So a lot of thoughts and debate about transmission. Initially, when we didn't know this disease that well enough, people were worried that is there an aerosolic distribution? That means the virus is suspended in the air and you're walking across without contact with anybody. Can you inhale it and can you get infected? It is pretty clear now that aerosolic transmission of COVID-19 is a very, very small percentage. And it only happens when you're doing a procedure like you're intubating somebody, or you are using a nebulizer, or you are using high flow oxygen devices, or when you're doing dental procedures where you are budding and drilling and creating an aerosol. That's the only time you have these viral particles, which are small pieces of RNA that are in the air, and you can inhale them if you're not wearing the right protective equipment. But majority of the times, this transmission is a droplet transmission. That means I coughed and did not have a mask on, or I did not sneeze into my elbow, and these fomites, these small particles that have virus in it, started and sat on a table, or I used my hand and then touched a doorknob and somebody else touched the doorknob, and they could pick this up, and then if they touched their face, that is how they would transmit. So as long as we have those three portals, the portals are primarily eyes, nose, and mouth. And eyes have this amazing ability to protect and filter out and not be able to, you close your eyes in a reflex and you're not able, you don't get the transmission of the virus, but the mouth and the nose, and that's why the masks become important. There was a lot of fear when earlier a New England Journal of Medicine study came out saying that these particles can sit on cold surfaces or on cardboard surfaces or on steel for 24 hours. That's really in a lab setting, not a real life setting. In a real life setting, it is a few hours, and the transmission won't happen if you're washing your hands or covering your face. And like I mentioned, the mortality is in the 1 to 3% range, but if you look at the real mortality, when you measure all cases, it's probably 0.5%. That means majority of the people are not symptomatic, and the ones that are symptomatic, majority of them don't need to be admitted, and the ones that need to be admitted, few of them that get on a ventilator have a risk of death. Next slide. So here is what happens. The initial phase of the virus is that when it gets typically through the nose, there's a receptor called angiotensin receptor, which is the same enzyme that we sometimes block in patients who have blood pressure, and to block and to lower the blood pressure, it's the same receptor. So the virus gets into your nose, gets into the respiratory tract. Then there's a viral response phase, which is the initial phase. Now, majority of the people who die and who have this remarkable X-ray where it's complete whiteout is not as much because of the virus as it is the response to the virus. That means that it's like an allergic response, that host inflammatory response that the body reacts to. In your world, all of you are dealing with patients with cancer. It is similar to what we see in cytokine response. I mean, somebody who has a high-grade lymphoma or is undergoing CAR T cell, when we treat them with chemotherapy or we treat them with CAR T cells, the cancer cells die and release these cytokines that can cause havoc in the body. And so we have experience with this by using drugs like tocilizumab, which is an IL-6 inhibitor, and that's actually the same drugs we're using to buffer this inflammatory phase and to prevent or decrease the impact of this inflammatory phase. We sometimes use steroids. We don't want to use steroids in the viral response phase because we want the body to fight it, but we can use it in the host inflammatory response phase, which is the reaction of the body to the virus. Next slide, please. So here is where we are in this country. The top graph that you see, which has this picket fence kind of appearance, is United States. And really, a high rise in the mid-March, late March, and in April, as we're decreasing down, we are nowhere close to the plateau. Realize that if you took New York, New Jersey out of this, this graph would not look similar. New York, New Jersey has now shown a decrease, a significant decrease in the new cases, and a lot of other states still have an increase in those cases. The picket fence kind of numbers that you see is because of the reporting structure. So if you don't report on a Saturday, Sunday, you feel like the number of cases are low, and then on Monday you report, and that's why it goes higher up. And it's similar to what you would see on the, if I had to plot a graph for deaths that are related to COVID. Next page, next slide. So a lot of people have asked about masks, an N95 mask. I want to give you just an overview of that. This is primarily a respiratory disease. It's not an airborne disease. So masks, wearing a mask and protecting your eyes and nose and washing your hands is probably the best way to decrease the transmission of this disease. And N95 means that it is the mask that you're wearing is not resistant to oil, and that 95% of airborne particles are filtered by that. Even a surgical mask, the way this virus is moving through contact and through fomites, you can just wear a surgical mask or a cloth mask, and majority of time it protects you from touching your face and touching your mouth, and that would decrease the risk of transmission. Next slide, please. Yeah. So testing is another thing that becomes critical in identifying things early. There are 3 types of tests. One test is the test of checking whether you have active disease in the nasal passages. So both being able to take the sample correctly and having a sensitive enough test becomes important. So here is the first slide, shows this nasopharyngeal swab has to go way back, not how it is shown in this picture, and collect that sample. And we basically use a PCR to multiply that, the RNA, and then we test it by an antibody and see if there is SARS-CoV-2 inside the nose. There are some transmission that happen through fecal-oral route, and if somebody has bad diarrhea and that's where they're getting this, the COVID-19, you would not be able to test it this way. The other test that people know of is the serology test. That means you're testing the blood, and you're testing the serum to whether the body had formed an antibody towards the virus. Now, we have to be careful with this test, because some of these tests that we have right now in the market are tests that are not really specific. That means the other coronaviruses that I showed you, they can cross-react. So even if it is positive, it may be that you have not had COVID-19, you have had one of the other coronaviruses, and that the test is coming back positive. None of these tests, neither the PCR test nor the antibody test, is FDA approved. They give you an emergency use authorization, which is called an EUA. So we don't have the testing, the regulatory component and the rigor towards whether this is a good test or not. There's another third test that is called an antigen test, where you would use a similar swab that you use on the nucleic acid test, but then you would use an antigen similar to what you would do for a strep throat, and you would have a different color, similar to what you do for a pregnancy test. And that test is helpful in a spot analysis just being developed, and we do not have clear idea about how sensitive or specific it is. Next slide, please. So the last one, I want to talk about the treatment briefly. There really is no approved medication. There are clinical trials, both using plasma, whether that's pooled plasma or individual plasma from patients who have had COVID-19 in the past. It is in a clinical trial. The thought is that it has antibodies in it that would neutralize the virus and would help. The other drug that is used is called remdesivir, again in a clinical trial, and is not as easily available to treat because there's limited supply of remdesivir. Some of you may have that available for treatment in high-risk patients. The other drug that I talked about is these IL-6 inhibitors to prevent the inflammatory phase, like tocilizumab or saralimumab. that we have experience with as cancer centers that we treat cytokine response to that. We try to avoid corticosteroids, especially in the initial phase, and the drug which I have a lot of experience with, having come from a malaria endemic area, which is chloroquine and hydrochloroquine, we need to use with really, really high level of caution. And definitely the combination of hydrochloroquine and zithromax or zithromycin is a dangerous combination because it can lengthen you what's called the QT interval and can cause arrhythmias in the heart. So in essence, no clear-cut treatment, especially supportive treatment in this disease, and clinical trials on both plasma and on remdesivir. Next slide, please. I just want to give you a brief input into what we have done, maybe a couple of thoughts. We have at City of Hope, we're proactive about this. Even before anybody was talking about social distancing or not going to meetings or limiting the number of people in a room, we understood it early, and as I'm sure most of you have, we have to have a very strict infection protocol. We are a very high number, we have a very high number of hematological patients, especially bone marrow transplant patients, that we become very finicky about infection control. We were wearing masks much before COVID-19 came about, and due to that, we have had a limited number of very, very few single-digit number of COVID-19 patients in a hospital, and that has put pressure on our other areas where a lot of the patients that would have been treated at other places come to City of Hope, and we have been full through all of this, creating an isolation unit very early on, making sure that they are negative pressure rooms, making sure that they have a separate entrance and a separate even CAT scanner and a separate X-ray has helped us prevent the transmission. And I want to just focus on one thing. It's all about prevention, hand washing, masking, social distancing. And while there is not a very clear-cut end to this, I think this is going to stay with us for the next year at least, and we need to be prepared for the long haul. I will stop here and want to make sure that I answer any questions if they come about. I know I've passed my time.
Thank you, Dr. Trisal. We have not yet received any questions from the chat room. So if we can, and thank you so much for this informative overview. I hope you can stay with us to the end in case people have some questions for you. And Melissa Childress from Winship Emory will be our next speaker. Thank you so much.
Hi, good morning.
Yes, absolutely. Happy here.
Sorry. Thank you, Dr. Trisal. Good afternoon or morning to everyone on the call. Thanks so much for giving your time for this what we hope is a series of interactive conversations around how we're all dealing with COVID, and more importantly, how we're all going to continue dealing with COVID as we get back into our new normal. And so Joel and I just wanted to take a moment to go over a couple slides on each of our home institutions, with the idea that hoping that some of you on the call volunteer your home institutions for some more learning and best practice sharing moving forward. So basically at Emory, we've really taken an approach that we need to continue doing the good work that we were doing pre-COVID and figure out how to leverage COVID to accelerate some of that work. So we were on a journey, we're still on a journey, to implement a foundational lean operating system throughout Winship and Emory Healthcare in order to provide a new care model for our cancer patients called the Winship Way. So unlike some of our peer institutions, Winship is a highly matrixed organization that's the cancer center that lives on 8 of the Emory owned campuses, and we do have a proton center. And so our work is really a how do we deliver standardized care in a decentralized model, and how do we set up a foundational, a solid foundation to make sure that really is consistent. And so we decided to use the COVID to really accelerate some of that work in keeping with our tiered huddling system and then adding a 4:15 call every afternoon, which is a multidisciplinary Tier 4 huddle that has our physicians, physician leaders, nursing, APP leaders, and operations leaders on the call at 4:15 every day to really prep for the next day and to understand what our risks are in the system with PPE, with staffing, with infection control, with door screening, et cetera, et cetera. And much like Dr. Trisal was saying earlier, we really kind of locked down our buildings earlier than the rest of the health system because of our the nature of the patients that we take care of. So putting door screeners at the doors early, masking patients and staff earlier than the rest of the health system, and really making sure that we kept a line of sight to what was going on in our centers. We also cohorted physicians and APPs. So we did follow New York or learn from New York early to say, how can we make sure that we protect our providers? And so early on, we put them on a 2-week on, 2-week off rotation with the idea that we could keep them safe and have backup plans should the worst happen. We have since come off that cohorting. I know you all probably have seen our governor in the news. Georgia is one of the earliest states to open. So we felt like it was important to figure out how we come back to a new normal earlier. So the cohorting has ended. And so we are moving back into a combination of the inpatient or in-clinic visits and telehealth. So during the what we consider the intense part of the epidemic, March through April and into early May, Winship continued to see more than 1,000 patients a day in our infusion centers, radiation oncology centers, and clinic. And that was a pretty heavy lift in making sure that we kept close monitoring of our staff to make sure that the staff spread was mitigated. That social distancing was kept. So we immediately took out 30% of our waiting room furniture and put it in storage. And then to the degree we could, moved chairs around, blocked conference rooms, made all of our meetings virtual. And then our research endeavor hasn't completely shut down, but all of our basic scientists came out of their buildings and went home to research basically. And then if they had to come into their labs, they came in on third shift when there were no patients in the buildings, because we do have many shared buildings on campus that are lab and clinic. Our CTO staff also went virtual for the most part, and then came on campus when they did an enrollment. So our clinical trials enrollment has been pretty steady through this crisis as well. And then we implemented telemedicine. So really looking at what were the appropriate patients, how do we set up the physicians' calendars, and we're going to keep telemedicine in a more of a 70-30 ratio of 70% in-person, 30% telemedicine moving forward. So finally, we set up a COVID acute care clinic for our cancer patients. One of the things we wanted to be mindful of is that our cancer patients do have temperatures that are not COVID related, and making sure that they were screened most appropriately. And then if they were febrile, we put them in an acute care clinic so they could be monitored and tested for COVID as appropriate. And so finally, the screening calls and clinic prep. So we really set up every patient is getting a screening call, and to understand how they're doing, if they're symptomatic, and then what we need to do with them through all of this. So those were some of the tactics we used and are continuing to use as we continue to open up. So I will stop and let any of you answer questions or ask questions, sorry.
So we have not yet received any questions. Please, those on the line, feel free to jump in on the chat function. Melissa, I wanted to ask you a question.
Sure.
How did you decide which patients you would use for telemedicine visits? How did you implement that? And you talked about wanting to go forward with 30% of your patients using telemedicine?
Sure. So one of the things we did early on was to pull a multidisciplinary group around the table and understand from the providers and the staff the appropriate triaging for a telemedicine patient. So we actually have an algorithm we work through to appreciate what's an appropriate telemedicine versus what's an appropriate in-person visit. So for example, if it was a lab-only visit, Emory has labs out throughout the community. Instead of bringing them to our normal cancer labs, they went to the community lab, and then a telemedicine visit was scheduled to go over lab results. Survivorship is another key area. So patients that were having their annual check-in with us, a lot of those went telemedicine, and also radiology. So if it was a radiology only, those went telemedicine as well.
Thank you. Any other questions from those on the line? I have one other question for you before we move on to Joel, and that is, I know a lot of people on the phone are in different phases, you know, some coming down the plateau, some plateaued, some still climbing. And a lot of people in real time are trying to decide what the runway forward looks like. Are there any special things that you're planning at this time that would be beneficial for folks to hear about?
I think that the message I would send is, you know your patients the best as cancer administrators, cancer operations, cancer providers, and to really rely on your multidisciplinary team to make those decisions together. So I'm proud to say one of the things really happened during this crisis has been we have come together as a group in daily meetings, and we, you know, as hard as it is with the pressures about finances and the pressures about, you know, social distancing and things like that, I would say cancer as a specialty is probably a bit more ahead of the curve than some other specialties, because this is what we do. And by virtue of taking care of immunocompromised patients daily, by virtue of the care delivery models we have set up in our institutions, by virtue of treating the BMT population and having to pay special attention to all the other, what I call little beasties out there, being attentive to all that and implementing and staying the course on your best practices would be the thing that we continue to latch back to. So, and I would say in this period of time, it's nice to be in cancer because we have a lot of specialists in our court who actually understand how to protect our staff, our patients, each other in different ways.
So
and I'll ask Dr. Trisal about that.
If I can interrupt you for a minute, Melissa, that leads into, we have some questions now, and what you just said leads into one of our questions, which is how have you involved, how have you been protecting staff and screening them during this?
Yeah, so the staff screening question is a very interesting question. All of our staff get screened. We have door screeners, so they get screened for symptoms coming through the door. Temperature monitoring is something that our organization is just now exploring because there is varied evidence about temperature screening. All of our staff have been asked to temp screen at home in the mornings and evenings, and not to come. We've been bullish about do not come into work if you're sick. I will tell you that in Georgia, when this hit, it was the worst allergy season we had on record. So one of the things we struggle mightily with is it COVID or is it allergies? And that may sound really weird, but we've had staff who have thought it was allergies and it's actually been COVID. So we early on set up staff testing and had a COVID staff line set up that if they had a question, they'd call the COVID staff line. It was answered by APPs who would screen them. And if we had any suspicion, they would be brought in for testing and asked to stay home. Masking, according to our ID teams, has been the most effective thing we've done to protect our staff from each other. And because that's actually what it is. Our patients are really good about keeping care of themselves, social distancing, masking, et cetera, et cetera. So it's been mostly the masking and the self-monitoring and monitoring each other. One of the things we really needed to do is to pay more attention to each other. And you'll often hear a staff member ask someone else, like, are you doing okay? Do you feel okay today? If we have any inkling somebody doesn't, we immediately get their supervisor involved and get them evaluated and sent home.
Thank you. We've also had a question about how you're prioritizing surgical patients as you begin electives again.
So our surgical process was quite interesting. We immediately shut down most surgery. We kept the required surgeries going minimally in order to preserve PPE and ICU beds for COVID. We had ratios of how many COVID ICU beds we needed based on our population and experience from other organizations and availability. And as we're reopening, one of the things that's happened is each hospital has a mitigation team that when we need to schedule a surgery, that mitigation team evaluates the surgery, understands the resource needs for the surgery, understands what beds are available, where the surgery can be done. We moved surgeries around to different hospitals that had more availability. And that's still going, but now we are moving into block time. So we are, our surgeries are back about 75% of surgical volume pre-COVID. That was the last news yesterday. And now they're starting to move into block time. And what we're doing is we're keeping the ability to shut it back down should we need to if we get a surge.
Thank you so much. We've had more questions for you. If we could move on to Helmke. We'll reserve time at the end for the additional questions that have come in.
Great.
Thank you,
Thank you, Nancy. Hello, everybody. It's an honor to be here today to share a little bit of our perspective from our experience out here at City of Hope. You know, as many of you are aware, the state of California moved early and rather dramatically once it became known that we had you know, exposure in the state and what appeared to be community spread very early on in the process. So in reaction to that and the stay-at-home orders that we received that impacted not only the workplaces but also the schools, etc., we ramped down our on-site volumes rather dramatically, very, very quickly. Tried our best to empty out clinics, tried our best to lighten the surgical schedule and only focus on acute needs, all in an effort to, you know, depopulate the campus. That's really what we were trying to accomplish. Like a lot of you, you know, for us as a cancer hospital, we were playing defense with COVID. You know, our objective was to keep the virus out of our facilities. We established, pardon the military parlance, but a perimeter around all of our patient care facilities, had very tight controls over access points, reduced the number of doors into these facilities that were open and available. And for those of you that may have ventured onto our campus over the years, you know, that was quite a challenge for us. We have a 100-acre campus, very open concept, you know, being in Southern California. But our nursing staff and our facility staff did a fantastic job of really kind of locking that down. The screening efforts were deployed immediately. We were screening patients, we were screening staff, temperature checks, questionnaires. The content of the screening questionnaire has evolved over time as new information has become available, as we've identified risks that on our own that have been a problem for us. We've incorporated that knowledge and learning into the screening process. But probably the most challenging aspect of all of this, and I'm sure many of you have gone down this road as well, we placed some significant restrictions to our visitor policy. Caregivers were, you know, very limited in their ability to accompany their loved ones onto campus. that of all of the changes that have occurred has probably been one of the hardest things for us to do, given the compassionate nature of our staff. But we have found ways to make that work. We are now working to prepare ourselves for what is typically a hot summer in the San Gabriel Valley out here, and standing up facilities so that our caregivers can wait for their loved ones while they're inside, being attended to by physicians, getting procedures, that sort of thing. The next thing, like many of you, we've all gained a much greater appreciation for the supply chain professionals in our organizations. PPE was, just a daily battle very, very early on, maintaining inventories, making sure that inventory management was very, very controlled. We sourced very aggressively. Beyond PPE, there were some other critical supplies that it seemed like everybody in the country was chasing simultaneously, like nasopharyngeal swabs or viral testing media. Worked very hard to ensure that we had adequate access to those materials so that we could continue to test patients, symptomatic staff, that sort of thing. But in addition to that, we, as CDC guidelines became available, we started deploying a recycling program that kept much of our inventory in play. We began to quickly realize that our habits in the PPE environment were rather wasteful. We actually developed a strategy to make face masks more widely available to all employees, whether they are in patient care roles or not. But through changes in our utilization of these materials, we actually reduced our overall daily utilization of masks and other materials, while still making more masks available to more individuals. So that was a clever way to really stretch our inventory. We relied on our our infection preventionists. There you go, got that out. To develop and deploy a very robust tracer program for the inevitable exposures that did occur. They did a fantastic job. Every time we would have an exposure, we would take learnings from that experience and put them back into our programs to better screen and better advise our staff on how to avoid high-risk situations. To facilitate testing of patients and any symptomatic staff that we had, we launched a drive-through testing program. So set up a tent, would test people in their cars, was felt to be very low risk, and has performed quite well as we have done pre-procedure screenings for patients that may be getting a high-risk procedure that includes aerosolization, that sort of thing. Probably the most dramatic change that we saw to our campus, though, was the shift to remote work arrangements. Prior to COVID, we had about 200 employees that would work routinely from home, out of an organization of, I guess, maybe 6,000. We have since shifted about 3,500 people to remote work arrangements, and this was done in a matter of weeks. Obviously, we had to obtain hardware, laptops. There was a lot of software and other communication apparatus that had to be deployed through our IT team. They worked literally 12, 16 hours a day, 7 days a week until we moved thousands of people to home. And so far we've been able to sustain business, but we're still learning what that means for the organization. Next in sort of our hierarchy of needs, we needed to maintain access to patients. We had obviously quite a number of patients who were under active treatment, similar to Melissa's experience. We had thousands of patients coming through for ongoing infusion therapy, ongoing radiation therapy. We had a lot of new patients that had visits scheduled. And to facilitate this, we had, again, another very, very rapid deployment, in this case, our telemedicine program, which was on our roadmap. Was expected to take 6 to 8 months to stand up, and again, was seen as a strategic priority for our organization. I think we stood up the program in weeks. Now, it's not deployed optimally. There are some clunky aspects to it. It lacks the level of integration that we eventually hope to see between our telemedicine platform and our EHR, but it's up and active and is currently supporting, similar to Emory's experience, 25 to 30% of our E&M visit equivalent volume and activities between patients and caregivers. We quickly identified that as volumes ramped down, we had several locations that were really operating at a very low level of throughput. We consolidated some of those locations to achieve better economies of scale. We deployed a variety of communication channels to get information out to our patients. Let them know about changes on our campus. Let them know about the screening procedures. Let them know about the visitation changes. Let them know to bring digital devices with them so that they can be in contact with caregivers who are not allowed within the perimeter. This included heavy utilization of our web effort, social media. We emailed tens of thousands of people and was able to leverage our newly acquired SMS text system to, again, get refined messaging out to our patients and their loved ones. We found that one of the more efficient ways to approach this too, though, was really to have the website be our source of truth. Easier to update one source than 20. So a lot of our email communication, SMS text communication, phone communication, etc., redirected patients to refer to our website for the most current information. And that seemed to work real well for us. As we have gotten deeper and deeper into our COVID experience, we've also gotten much more granular into the data that we have to understand both demand and supply of services within our organization. We've identified leading indicators that we're tracking on a daily basis. Everything from new patient appointments, which everyone seems to be tracking anyway, but getting much more granular, as a for instance, into our call center volumes. Are the phones ringing on the referral lines? To what extent are they ringing? What disease sites are they ringing for, etc.? And again, being able to sort of react to that and plan prospectively to accommodate that volume. Turn to page, please. Another key area of focus is, we quickly recognized that not only were our staff being significantly impacted in the workplace, their lives were changing, how they navigated the campus was changing, the number of precautions that they had to take on a daily basis were changing. For some, it wasn't that big deal. It wasn't, much of a change from what they're doing before. Our nurses on the hematology floor, etc. They've always lived like this. But for the registrars, the patient access staff, the facilities staff, etc., it was a pretty dramatic change for them. And on top of all of this, they had kids who were being sent home from school, people who were working remotely. Not only were they juggling their jobs, they were also learning how to homeschool their children. So we invested heavily in programs to recognize our employees, engage with them, to show our appreciation for them. We had I think, an extremely well done marketing campaign that was really focusing on our employees as our target market. The City of Heroes campaign, very, very well done. Provide us with an opportunity to shine a spotlight on some folks who are really going above and beyond the call of duty. Also within this period, we had several recognition weeks that occurred. We made a point not to forego recognizing our lab professionals, recognizing our nurses or other hospital staff during these recognition weeks. We made an exceptional effort to help folks know that they are appreciated and we are with them and we understand the duress that they are operating under both at home and at the workplace. The third bullet here is just a quote that was drilled into me as a very, very young administrator by Larry Mathis, who was at the time the CEO of Houston Methodist in the 90s. I had an opportunity to visit with him as a very low clinic supervisor, but he was very kind and gracious, and he drilled into me. He said, listen, you know, your jobs are going to be hard, but one of the things you can remember is you can never be too gracious to people. You can never be too grateful. And one of the aspects of our communications to employees that I was so very pleased to see and so very proud of is that Robert Stone, when he addresses our citizenry here at Seed of Hope, he begins and ends with thank you. A very simple gesture, but I think it's something that has meant a lot to our teams, the folks who are, you know, really carrying a lot of water for the organization right now in the COVID environment. In addition to this, we've also fed a lot of people. We've offered you know, free food and meals regularly to staff that are on their campus and engaged. For those of you that know the In-N-Out hamburger chain, you know, we bring in their food trucks. Not as good as Whataburger, if you ask me, but still, it's a good hamburger in the state of California. And you know, just trying to do as much as we can to show our appreciation to people. In addition to that, our leaders have worked to be exceptionally visible, whether that be Susan Brown, our Chief Nursing Officer, myself, Vijay Trisal, our Chief Medical Officer. We're in front of staff, we're, you know, at meetings, we are showing up, we're in the hallways, we're letting folks know that this is a group effort and we're all part of the same team. And that's, I think, gone a long way to motivating and sustaining that enthusiasm. Around the issue of communication, we communicated via a very dedicated and well-organized communication chain. That structure has been in place very early on. The hierarchy for that structure extends to our most senior leaders so that we can, again, be on message with key communication points, trying to make it sort of short, sweet, and high value as much as possible. We also, on a weekly basis, distribute really kind of our list of accomplishments. This is what we did. This is what we're able to obtain. This is, you know, some of the accomplishments that we've had, whether it be standing up the isolation unit or our febrile clinic, or you know, being able to acquire significant PPE, or, you know, being able to attain some support to help us bridge through this troubling time. We've made sure that everyone understands what we are working on and what we've been able to accomplish over the last week, and that's been a real shot in the arm. And we've also worked to ensure that our communication goes from a very high level to a very local level. Daily huddles, daily rounding, to accompany the sort of higher level organizational enterprise-wide communications that we're getting from above. And again, going back to the very critical point of messaging our patients, helping shape their expectations for when they arrive on campus. What is that going to look like? What does this mean for you as you're, you know, getting out of your car, going through the valet, getting screened? What types of questions, you know, should you expect to have to answer? What do you, you know, what's going to happen to your caregiver while you are in transit to your visit if they can't be with you physically on the campus? That has been a key track of communication. Next slide, please.
Joe, we're getting close to time. If you don't mind summarizing your last slide, we just want to make sure we have a minute or two to hear from folks. We've got a lot of questions, and I'll speak to that after you're done. Thank you.
Absolutely. You know, looking ahead, you know, obviously this is going to change the dynamic of cancer care for quite some time. Things we expect to see as people sort of return to a normal normal frame of business is we expect to see more late-stage disease presentation in cancer. We know that a lot of the screening modality volumes are down. Folks aren't going to the doctor. You know, folks who would typically go and get that lower abdominal pain checked out, maybe you're more hesitant to go see their primary care physician. And we also expect that many of the comorbid conditions that we see alongside cancer are going to be exacerbated from the lack of access to physicians and other clinical care. We expect that as the unemployment rate continues to increase, we'll see an erosion of payer mix, increase the number of uninsured patients presenting. And on top of all of this, you know, we're going to have to figure out how we're going to be managing the new normal. Going back to the issue of managing a remote workforce, how sustainable is that in our current model? What does that mean? what amenities or structures or plans need to be stood up and able to effectively manage that workforce in a very productive way. And then again, we'll continue to see challenges to the supply chain as infection rates ebb and flow, new states have flare-ups. Again, this is a global issue. We have global supply chains, and I think we'll all struggle with that together. That said, there are some opportunities and some accelerations that have occurred from all this. Again, the advent or the extension of telemedicine into deep into cancer care is going to be a wonderful thing for patients that need to access care, especially those who may live distant from a major urban area. Workplace flexibility, being able to attract talent without necessarily having to require that talent to live where your facility is. I mean, it's conceivable that we could have a distributed workforce nationally, depending on our reliance on technology to drive coordination. We expect that cancer, since the relative risk of a cancer diagnosis to a COVID diagnosis is much more significant, that cancer is likely to return in volume within our medical centers and our integrated health systems, as opposed to some of the other key service lines like musculoskeletal, et cetera. Cancer is not going to take the day off. Those conditions are going to continue to grow in acuity. And again, we're going to be getting adjusted to a more rigorous infection prevention culture. But again, to what Melissa stated earlier, this is who we are. This is part of our DNA in oncology. We deal with immunocompromised patients all day long, and this is something that we do extremely well. And just the last point I want to leave you with, as I was thinking about all of this yesterday, this is not the first global pandemic that we have experienced that has resulted in fundamental changes in medicine. For those of us, in that sort of 45 to 65 age bracket, remember the impact that HIV had globally on medicine. It wasn't known at first. We had to develop a learning curve, had to understand what we were dealing with, but ultimately it resulted in some pretty dramatic changes to our clinical practices. So, this isn't our first pandemic, and I think it just emphasizes the fact that during these times, we need to be more concerned about collaboration and less concerned about competition, and just join hands and try to help each other as much as possible. And I'll take any questions.
Joel, thank you. We are at the time for our seminar to end, but what we'd like to say is we would like to keep the line open for chat questions. What we plan to do, first of all, very kindly, if you look at the slides, our panelists have provided their contact information to ask questions. They are happy to do so. We are going to have another webinar on June 10th, presented by ECG Management Consultants, relative to the COVID-19 webinar series. We also would like you to pose the questions that we have, about 5 questions that people sent in through the chat room. We encourage that those questions be put in the chat room, and then we can have a very broad response in addition to directly asking those questions of our panelists. I'd like to thank you for your participation today in the seminar. We look forward to having you back. We look forward to hearing from you so that we can have the questions and learnings that you have shared with the membership. We appreciate your time. Thank you so much.